So before I start, I'd like to acknowledge that although I'm the one here presenting today, this is absolutely a collaborative piece of work. So I'd like to thank all my colleagues in Papua New Guinea and Australia, and to actually acknowledge Cherie Bennett, who's here. She's in our inaugural project manager for this program. So great to have you, Cherie. So why Papua New Guinea? We have around 70,000 people living with HIV, and unlike the rest of the Asia and Pacific region, about 60% of all our people living with HIV are women. So it means that issues of women and children and mother-to-child transmission are pertinent in our country, at a scale that maybe not in other parts of our region. For a sense of brevity, I'll just say that, at the moment, our mother-to-child transmission rate is at 32%. This is estimated through Spectrum. So this means a child who is born to a woman living with HIV in Papua New Guinea has a greater chance of being infected with HIV than a child born in sub-Saharan Africa. So we have around 3 children born each day with HIV. We've had a long turnaround time of infant diagnoses. In one of the clinics we work in, that was 21 weeks prior to our work. So 21 weeks from the time a baby was tested to getting the results back, which meant that many children were being clinically assessed in the ward with AIDS and started treatment then. There was no point of care viral load testing. Viral load testing coverage at the time our program started for the country was around 2%, and there was no focus on paediatric viral load at all. So children were definitely leaving behind. So ACT UP, for those of you who feel like dinosaurs with me, we did draw on the New York activist group to really accelerate the uptake of innovations for the detection and monitoring of HIV in adults and children and drug-resistant surveillance. We felt that the urgency in PNG needed the kind of amazing activism and rigour that those brave gay men initiated in New York in the 80s. So we drew on them. And so it was to build laboratory capacity to deliver faster, more accurate testing for viral load and EID testing, to improve treatment coverage and adherence, and to establish routine HIV drug-resistant surveillance. So we started implementing active program actionable drug-resistant surveillance prior to WHO's latest guidelines, which also recommends what we're already doing. It's exciting when PNG is ahead of WHO. Usually we're following WHO, so it was kind of nice. So let me just tell you so here we're working with children, we're not including adolescents, we're working UNAIDS guidelines of under 15. So we've tested, to date we've tested 1,849, and you can see the breakdown. And so Hillary Clinic, we started in May 2021, and we started at the Port Moresby General Hospital Well Baby Clinic in December 2021. So these are the 2 largest HIV treatment sites in the country, and they're 2 of 3 dedicated paediatric programs. So you can see we slow to start with. We only had 200 babies tested in 2021. We went to 655 in 2022, 830 last year, and up until April this year we've had 91. So we've done 1,849, unique children is 1,811. We've diagnosed 153 children. That's a positivity of 8.4%. Bruce has worked in PNG, so he understands that we can't tell you what the transmission rates are, because to get the denominators right is very difficult based on our current data systems in PNG. But we were proud to be able to get the HIV qual assay approved by the HIV Technical Working Group in PNG in May 2021, and we started testing immediately. And one of the concerns we have at the moment is that babies are continuing to still present late. So at the moment, 50% of all our children being diagnosed with HIV are over 3 months, so between 3 months and 12 months. So what we are at the moment doing is we've sought approval to initiate birth testing under WHO guidelines. You can do 0 to 2 weeks. That's easier said than done. We don't actually have any treatment regimens in the country for children under 6 weeks. Dolutegravir is not recommended under 6 weeks. So we've had to really fight hard to get raltegravir approved. Many people are concerned about drug resistance, but for us, we think the baby would only be on it for 6 weeks. Then we can move to a transition to a DTG-based regimen 4 to 6 weeks. So that's been approved. We're now waiting for the drugs to come into the country so we can actually start to accelerate treatment. So what about viral load? Many of you know that viral load amongst adolescents and paediatrics is far poorer than adults. And so what we've done is the Gene Expert machine can only be used ethically on children 10 and over because of the requirement of blood, whole blood needing 5 mils. So we did a validation on DBS on the Gene Expert. It failed at that time. We then explored other platforms and we have implemented the MPEMA. That took a very long time to get approved. Shireen knows that very well. There was real reticence to approve that platform. So now we're currently providing 2 platforms to provide point of care HIV viral load tests for our children to make sure nobody in PNG's epidemic is being left behind. So we've done 1,004 tests. That most of those have been of people on treatment, so 853. But of course, we've been doing the viral loads of children who are reinitiating treatment, so have been lost to follow-up, or those who have been newly diagnosed. And I have to go back. This woman here at the top, Sharon, she's amazing. She is one of the pioneers in paediatric HIV in Papua New Guinea. She has been working there from the outset, so she's quite extraordinary. And the photograph down the bottom was of an 11-year-old girl coming in to have her first viral load test done. So we really are seeing the spectrum of paediatric HIV. So we've been then looking at our data and looking at suppression. So of those who were on treatment, we've had 687. We have a sex equity. We've not asked about gender at this stage. We've got 144 children had a high viral load, so greater than 1,000 copies at the time of their visit. And of those, 97 were unsuppressed on routine on their first viral load. 47 of those were a repeat after their adherence counselling remained to be non-suppressed. So if we look at overall suppression in terms of their most recent, so some of these children have had multiple viral loads, we're at 79% viral suppression. So you can see here just quickly, here, the paediatrics are here, and they're doing much worse than the adults and even the pregnant women. So it really shows that we have a lot more work to be doing in this paediatric space. Okay, so HIV drug resistance. We weren't really asked to talk about this, but I'm going to do it because I think it's really important, and I think too much hope has been put on dolutegravir. So we're doing both routine pre-treatment drug resistance surveillance, but we're also implemented, and we're one of the first countries to do this, to do program actionable drug resistance testing. 85 of the samples of 354 at the moment are of children under 15, and this is the first time PNG's had any data on children less than 18 years or pregnant women. PNG, just to put some context, was the 5th worst country in the world in 2019 with drug resistance to NNRTIs at around 19%. So it gives some sense of why, for us, ensuring that we monitor DR is so important. So, not surprising, this is our data. So nearly 40% have baseline drug resistance, so 37%, 36.8% pre-treatment. So that's completely treatment naive. Obviously, there's a few less who are reinitiating treatment. But then we have 6 out of the 12 children who are reinitiating treatment, who had had a high viral load, went to enhanced adherence counselling, continued to have a high unsuppressed virus. 6 of those 12 children have drug resistance. At the moment, it looks good, and not surprising, any of these results, but it's not all great. What we have been able to do is to show the risks that high background drug resistance has for treatment. And so I'll give you this example. This 3-year-old boy, he was diagnosed in our program in December 2021. He had drug resistance done, and he shows that he has very high rate levels to abacavir and lamivudine. Based on his mutations, we changed his treatment to from Abacavir base to AZT3TC DTG. This child's mother died just after birth. He lives in another province up in the mountain areas, and it's about a 2-day drive. So it took us a very long time to get this baby back to change his regimen. But I'm really happy to say that now he's target not detected on the MPEMA, and he's a thriving young 3-year-old. DTG. So is it the magic bullet? Well, I think WHO's report in February this year shows that it's not going to be the magic bullet. I think it was Sudan had up to 19% DTG resistance. So I can say that we've had no DTG identified in children under 15. But what I can say is that we have had 2 people diagnosed with integrase, including a 16-year-old boy, which means he was actually younger when the mutation started. This young man's perinatally acquired HIV. He's a double orphan. His brother also has HIV. Like other people in PNG, he lives in a remote village, and it's been hard to bring him in. So you can see that his viral load was going up and up and up, and so his profile was reviewed. Unfortunately, the country had stopped procuring new paediatric LPVR because it believed that it wouldn't need it anymore, and DTG is all we needed. There was no adult LPVR in PNG. We got a donation from Sydney Children's Hospital to cover us for 6 months. We've had to get another donation. We've had to provide him significant care and support for adherence, school, etc. He's being cared by his auntie. And he was wasting, and he was around 38 kilos. He's now put on about 5 kilos. And when the nurses were talking about him, they were talking about him as a really bad, non-adherent patient. When we spoke to him, he's a tired young boy, tired of having to take drugs. But sadly, we wouldn't be able to, he would not be eligible for long-acting injectables. We, of course, as an anthropologist by background, I'm really committed to the social sciences, and we've done some really beautiful qualitative research by these 2 amazing people, Sujit and Ruthie, so it'd be remiss for me not to mention that. And I would just like to finally acknowledge the amazing people in Papua New Guinea who we work with, who have been really able to take the challenge to think differently and challenge the status quo and improve integrated testing for our children and ensuring that PNG doesn't leave anyone behind. Thanks so much.